Without further ado, I'm going to introduce Dr. Tagliati, our next speaker. And Dr. Tagliati is really going the distance today in many ways. He already ran a 10K race this morning, and then he raced up here to Santa Barbara. So we welcome him. Dr. Tagliati received his medical degree at the University of Rome, La Sapienza. He did his residency in neurology at the Mount Sinai Medical Center in New York. His fellowship is through Beth Israel Hospital in New York for Movement Disorders Program. He's a professor of neurology at Cedars-Sinai Medical Center. He started there in 2011 to present. And he's director of the Movement Disorders Clinic at Cedars-Sinai. So thank you, Dr. Tagliati, for being with us today.
What a wonderful turnout for the first day of the Parkinson Awareness Month, which is April, as you all know. I think that we're fixing, let me know when we are ready. 2 more minutes. So I can tell you about my race this morning. We should all exercise, as you know. 2 weeks ago, I had the honor of running the LA half marathon, which, as you may know, is called the LA Charity Half Marathon because it's reserved to people that commit to raise money for whatever good cause. The McCord Foundation, which organized the LA Marathon, is of course a major foundation for medical research, particularly MS, but we are trying to bring them to pay attention to Parkinson and neurodegeneration. And I'm going to brag for a second, if you allow me. I won my age range. But most importantly, we raised $140,000 for Parkinson research. So, and all through a generous donation of patients with Parkinson disease. No corporate donations, no banks or people with second agendas. So they were all grateful patients that all together brought in an incredible amount of support for Parkinson research, and in particular, and I'm going to keep on going while they do that, in particular for a project that we are pioneering at Cedars. Maybe we should talk with my friends at UCLA to take care of patients with Parkinson that are admitted in the hospital. As if any of you was ever admitted in a hospital, you know that the specifics of taking medication every 3 years, every 3 hours, every 2 hours, doesn't fit well with the hospital routine. And many patients, are we good? And many patients tend to fall through the cracks and stay in the hospital longer than they need to. So we are setting up a system so that no Parkinson patient is left behind. And this is something that we are working on, and this, that's it? We're ready? Wonderful. So what are we going to talk about today? Do this. I can use this so that I can move eventually. Yeah, let's see. What is new in the world of Parkinson disease? Well, let's start with the basics. What is Parkinson disease? Many of you may know that the term Parkinson disease comes from Dr. James Parkinson, that over 200 years ago described this involuntary tremulous motion with less than muscle power, in parts not in action, and even when supported. I'm not going to read the entire book to you. But he didn't call it Parkinson disease. He was not that self-centered. He called it the shaking palsy. But a few decades later, a famous neurologist, the French Jean-Martin Charcot, decided to honor the initial description of James Parkinson and add in a few features that now we recognize and in the diagnosis of the disease, and we'll talk about that in a second. He called it Parkinson disease. There is an interesting little trivia that I want to share with you. The face of Dr. Parkinson is not known. For many years, myself and many others of my esteemed colleagues, told the public that this was Dr. Parkinson, not knowing that this guy, although his name is James Cumming Parkinson, had nothing to do with our hero. In fact, he was born after the description of the shaking palsy in 1832. But, you know, James Parkinson with a beard and old picture is something pretty good. So the only image that we have of Dr. James Parkinson may be this drawing from a book. This is the cover of one of his books, the Ale House Sermon. And apparently this guy that is giving a sermon to a bunch of beer drunks in this bar is James Parkinson. So a little piece of trivia, we do not have images of James Parkinson. He was a real guy. He existed. And we have, most importantly, his legacy through the essay on the shaking palsy. But if someone shows you a picture of Dr. Parkinson, say, that's not the guy, okay? Very good. A lot of time has passed from 1817, and we now have Parkinson's disease identified as the second most common neurodegenerative disorders after, obviously, Alzheimer's disease. It affects about 1% of the population over 65 years of age, which amounted to about 1 million people in the United States. Of course, it presents an enormous challenge to our society, to the resource of our society. But most importantly, and I don't know if you're aware of that, Parkinson's disease is the fastest growing or expanding in terms of patients affected by the disease, neurological disorder in the world. So the number of patients with Parkinson's has doubled since 1990 and is supposed to double again by 2030 throughout the world. So we definitely need to pay attention to that. And the good and the bad news is that there is an enormously amount of knowledge that is coming to us. And why do I say it's good and bad? It's good because, of course, you want to have the knowledge. It's bad because you need to know what to do with that knowledge, and it's not obviously always so obvious. I will try to tackle some of that with you. These are just the numbers that I just gave you. The doubling of the population of patients, of people with Parkinson's disease over the next decades. How do we define Parkinson's disease? This is something that, unfortunately, many of you are very familiar. While you see these old patients of mine in New York, we use what we call cardinal signs, bradykinesia, or slowness of movements, which is the key. Remember, tremor is not the key symptom of Parkinson's disease. It's the slowness of movements. You can have Parkinson's disease without having tremor, but you cannot have Parkinson's disease without having slowness of movements. And then in addition to that, we recognize the tremor at rest, the rigidity or muscle stiffness, and later in the disease, the loss of balance. And then we have a number of other problems that we all know, the masked face, the small handwriting, the soft voice, the very important, Parkinson is always worse on one side of the body than the other, but this is not new. Let's move on. So, and I keep on calling the current definition because I'm gonna walk you through what I believe is a more updated definition of the Parkinson's disease, but we know that it's a progressive, chronic neurodegenerative disease due to the slow and selective, which I want to put a cross on because unfortunately it's not selective, loss of brain cells that make dopamine or dopaminergic neurons, the accumulation of Lewy bodies, which are this cute little round accumulation of proteins in the brain cells, and especially in this part of the brain is called the substantia nigra. And the good news is that because of the loss of dopaminergic neurons, levodopa, which is nothing else than a precursor of dopamine, is extremely effective, and we'll see in a few slides. How do we diagnose Parkinson's disease? Well, first of all, and most importantly, we look at the symptoms and the signs. So if someone comes to us with at least 2 of those 4 signs, either the slowness and the tremor, the slowness and the stiffness, or all 3, of course, we make the diagnosis of Parkinson's disease. But we now have learned that there are many other what we call biomarkers. Biomarkers are basically medical measurements. It can be something as simple as blood pressure, for example, and can be something as complicated as a DNA test that will contribute to solidify, to confirm the diagnosis of Parkinson's disease. And but there are new ways to diagnose Parkinson's disease. This is, for example, is an amazing experience, and unfortunately, we don't have the. Can we have the sound? We don't have this. I know, because I forgot about it. Anyway, you will need to trust me. So this is Lori Mishley, that many of you, I'm sure, know. She's up in Seattle, and she has been training these dogs, and I've seen them myself. This is no YouTube, misinformation. This is truly an amazing phenomenon. These dogs are able to recognize these little samples that contain earwax of patients with Parkinson's disease, and they stop only in front of the containers with the earwax of patients with Parkinson's disease. Now, this may be a curiosity. Wow, this is cool. But this tells you that we can learn something, like what is in that smell, what is in that scent that the dog can recognize. This is absolutely amazing. If you ever have the chance to go up to Seattle, Lori organizes every year a Parkinson boot camp, inviting patients from all over the United States. This is quite amazing. But I said I wanted to distinguish the current with the new definition of Parkinson's disease. Parkinson's disease, unfortunately, is not just about slowness, stiffness, and tremors, but it's about a plethora, a big number of other symptoms that we now identify as non-motor symptoms, meaning symptoms that have nothing to do with the control of your movements. And you can see the list. We're not going to go one by one, but they go from sleep problems, from autonomic problem, blood pressure, constipation, psychiatric problem, cognitive decline, and even sensory problem, loss of smell that many of you are probably familiar, pain, tingling, numbness, etc. This has added a lot of complexity to our management of Parkinson's disease, because it used to be kind of simple. You have the tremor, you have the stiffness, here, take the Sinemet, and bye-bye. And now instead it's like, doctor, I have constipation. I'll never forget, I'm gonna take 30 seconds out of my lecture. When I was a fellow, I was really young. There was a time I was young. And I was very proud because they invited me to the Parkinson Unity Walk. Did anybody go to the Parkinson Unity Walk in New York by any chance? It was an amazing event with thousands of patients coming from all over the States. And I was a fellow at Beth Israel, and they gave me the Ask the Doctor booth. I was so proud. I was so ready. I knew everything about deep brain stimulation, gene therapy, stem cells, everything. The first patient come to me, he's like, are you the doctor? Yes. What about constipation? I'm like, oh, of course, constipation. You drink water, you eat fibers. I had no clue, obviously. Second patient comes, doctor, anything new about constipation? I was like, I'm in the wrong meeting here. This is a GI meeting. But it dawned on me that what we were worried about was not what our patients were worried about. And this is very important because, unfortunately, very often doctors don't make that. Oh, I like that. Thank you. And I promise I'm a doctor, okay? But we can do better. The non-motor symptoms are very important because, first of all, they're not some sort of late problems, after 10, 15 years. They occur very early. If you can see on the left of the screen, this is a study in which they look at 158 early Parkinson cases. They had Parkinson for about 6 months. And they already had, on average, 8 non-motor symptoms. So we have 2 or 3 motor symptoms and 8 non-motor symptoms. Is this a motor or a non-motor disorder? And then if we look at the end of Parkinson, meaning after 15, 20 years in the advanced stages, these are the symptoms: cognitive decline, depression, dysphagia, hallucination, urinary incontinence, postural hypertension. Do you see any tremor there? Do you see any stiffness? Do you see any slowness? No, because those are not the important problems. They're important to diagnose it, but we need to pay attention to a lot of other problems. Also because they precede the motor. As many of you, I'm sure, know, loss of smell, constipation, problems with sleep precede the onset of Parkinson's disease, to the point that now we can establish a risk of developing Parkinson's disease 5, 10, 20 years before the neurological diagnosis. And you can imagine the importance of that, because it opens a window of opportunity to maybe stop the damn disease from even reaching the brain. So this is something that we are studying on at Cedars. We're not going to go into details, but if you guys have questions later, we can chat about. But it opens the question of, where does Parkinson really start? Does it start when you have the tremor in the hands, or it starts sometimes 5, 20 years before with symptoms like REM behavior disorder or acting out dreams? How many of you is acting out dreams or used to act out dreams? Just by raise of hands. Look at that. A population of active dreamers. This sounds like a curiosity, but it's sometimes the first symptom of the disease. And we found out that Parkinson's disease may occur before birth. Before birth? You kidding, doctor? No, I'm not. We did a study with Dr. Clive Svensson at Cedars-Sinai looking at stem cells, not as a treatment, but as a diagnostic clue. And we found the stem cells of people that develop Parkinson very early in their life, sort of a subgroup of people, unusual, in their 30s, in their early 40s. When we look at their stem cells, they're already unable to handle alpha-synuclein. And they were completely different from patients with Parkinson that cells of patients with Parkinson, older or normal people. So the question is, and I don't have an answer for this, what is Parkinson's disease? Is that one disease with many faces, but with a common sort of pathogenesis, as we call it, with a common lead to the abnormality? Or is many diseases that have the same neurological symptoms? This is a key question that, as you can imagine, influences how we write clinical trials. Because very often, how many here participated to at least one clinical trial? Nobody? Wow, we need to work here. Oh, here, 1, 2, 3. We need to work on that, guys. More participation to clinical trials. But seriously speaking, what the problem with clinical trials is that sometimes we have someone improving amazingly and someone else not improving at all. The FDA look at it, does an average, this thing doesn't really work, and he throws it in the garbage. But for those few that improved, barring a placebo effect, that might have been a cure. And instead, it gets thrown away. Maybe because Parkinson's disease is not one single disease. These are questions that need an answer. How do we treat Parkinson's disease? Well, we had a long history. Many of you are very familiar with many of these medications: levodopa, apomorphine, dopamine agonists, UMT inhibitors, ergot. I'm not going to go through all this. There are a number of pills that you're all, unfortunately, very familiar with. The immediate release, carbidopa-levodopa, the extended release, carbidopa-levodopa, the dopamine agonists, the apomorphine, the rotigotine. I'm not going to go through this, also because it's nothing new. We have been using them for years and years, and they're extremely effective. I mean, for a number of years, this medication work very well. One question that I want to address, because I still hear people afraid of taking levodopa, is that should we spare levodopa? And the answer right off the bat is no. And I'll explain to you why, and I'll show you evidence of why no. So first of all, you need to remember that when we diagnose Parkinson's disease with the motor symptoms, we have already lost 50% of the dopamine in the brain. So if I ask any of you, if you lose 50% of your B12, would you take B12? Yes. If you lose 50% of your dopamine, why wouldn't you take the dopamine? There's no reason. There is a reason, of course, which is the fear of complications. But let's look at the evidence. So these are studies that follow patients with Parkinson's disease. They were initiated on levodopa or on other dopamine agonists, MAO-IB inhibitors. And they follow them for 6, 7, 8 years. And here is the effectiveness after 6, 7 years. Do you see any difference there? No. There's no difference. So starting the levodopa didn't make any difference in terms of the viability at the end. Oh, but I'm going to get the dyskinesias, doctor. I don't want to have the dyskinesias. We can talk about dyskinesias later on, but let's look at the results, not at the fears. After 7 years, people that had started with levodopa had about 35% chance of getting dyskinesias. 1 in 3. Those who had started without levodopa and therefore suffering because the alternative medication don't work nearly as well as levodopa, had a 33% chance of dyskinesias, which to me sounds pretty much the same. So you suffer for nothing. And the proportion of stopping treatment because of side effects, because of all sort of problems. So for levodopa, you can barely see it here. It's about 5%, 7%, while the other medication was between 50 and 75%, because this other medication have sometimes serious side effects. So again, what's the point? And let's go back to the dyskinesia. This is a very interesting study. This group of Italian researchers, I have a weakness for Italians, you can understand. Brilliant people went to sub-Saharan Africa. I think it was Ghana or Guinea. Forgive me, I don't remember the exact nation. And why did they do that? Because they wanted to compare people that have immediate availability to levodopa with people that did not have, for socioeconomical reason, immediate availability to levodopa. So they were left without levodopa for years and years. And they asked the questions, who's going to develop problems earlier, right? Those who start right away or those who wait 5, 6, 7? And the answer is they started to have problems, fluctuations, dyskinesias, at the same exact time. So what I like to tell my patients is like, don't think that postponing levodopa is gonna push the window of opportunity down the line. It's gonna just shrink it. You're gonna have less year of benefit from the levodopa. So that doesn't mean that you have to take a lot of levodopa, but definitely there is no reason, and I show you the evidence, it's not just my opinion, of postponing levodopa. Very good. Because also, Parkinson is not only about dopamine. This brings us back to the non-motor symptoms. And so you see that neurologists now have to, at least neurologists that take care of Parkinson's disease, they need to become expert in dementia, in depression, in anxiety, in sleep abnormalities, in urinary frequency, orthostatic hypotension, which means that your blood pressure falls when you stand up, making you dizzy or lightheaded, in constipation, as I've already told you, which introduced the concept of multidisciplinary approach. The future of Parkinson's disease, we're starting to move the first steps. We have a multidisciplinary clinic at Cedars-Sinai. A few major centers are moving that way. But Parkinson's disease cannot be treated by one doctor. There's no way. no matter how smart we believe we are, we cannot take care by ourselves, and I'm talking about neurologists. Of course, we can lead the team, but we need a number of competencies that will help us taking care of all the non-motor aspects. And then there are the motor fluctuations. We already talked about that, but whether you spare levodopa or not, after about 5 to 10 years of treating successfully Parkinson's disease, there are the motor fluctuations. The wearing off, the dyskinesias. There are a number of definitions that we don't need to go in details. And the good news is that there are a lot of treatments because it's such an important problem that we have developed a lot of strategies and solutions. You adjust the doses, more frequent, less frequent. You add on other medication to help that levodopa last longer. Now we have non-oral therapies. You see transdermal, the patch, subcutaneous. I'm going to give you a little bit more details because that's truly new. Intrajejunal pumps, sublingual, inhaled. We're going to throw in the levodopa from whatever port we can use because we know that is extremely important. And then there are surgical treatment, deep brain stimulation, focus ultrasound. We're going to talk a little bit about that too. These are just a nice long list of the medications that we can use to treat motor fluctuations. And a few words on the infusion therapies, which are the new sort of attempt to keep that flow of levodopa constant in the body. The levodopa pump. Is anybody here has a levodopa pump by any chance? I can see it. One. There you go. One. Yeah, unfortunately, it's not really taken off very well in the United States for a number of reasons, which is not the right sort of stage to discuss. But the results are quite impressive. I mean, increase in on time, decrease in off time. But it's a complicated procedure. You have to put that tube in the stomach. So now they came out with subcutaneous levodopa pumps, much easier to use. You see, it's like a little Band-Aid, almost look like, with a teeny tiny needle. And it's very similar to insulin pumps that people with diabetes use. And the initial results are now being published both for the AbbVie and for the Neuroderm pumps. There are two different companies that are working in parallel. I mean, they're competing with each other, but to your advantage, they're working in parallel. And we have been part of the testing sites, and I can tell you that it really works. Our patients that were involved in the studies were quite happy, with one possible exception, which is that because you have to stick this needle, you get a lot of reactions or a lot of skin reaction. But most of our patients were like, it's okay, I don't care about this skin reaction. So it depends how much those bruises and the reaction will bother each single patient. The FDA has kind of put a little bit of a pause in the approval for some question that they had on the, I guess, on the quality of the product, but this is going to come out pretty soon in my expectation. Then there is, of course, deep brain stimulation. Who has deep brain stimulation here? You see more than the levodopa pump, or many on my side. Very good. So deep brain stimulation was considered the second revolution of the treatment of Parkinson's disease after levodopa, of course. And it really changed the way we look at the disease. It added another 10, 15, 20 years of absolutely beneficial time. This is one of the first trials. We don't need to go into much details. But what is new in deep brain stimulation? Well, they came out with these segmented leads that allow the programmer to focus the electrical field to the sweet spots, trying to avoid side effects. This is the multiple independent current control that Boston Scientific came up with that allow us to fraction the electricity in different contacts. These are the visualizing software, so we can now see in each single brain where the electricity is and try to shape that field. And this is the ultimate sort of holy grail of the brain stimulation, which is the feedback loop that hopefully in the future will allow the device itself to control how much electricity is needed to control the symptoms. Something is still available, something is still is not approved or established yet, but definitely there is a lot of research ongoing in the brain stimulation. And this is MRI-guided focused ultrasound, which is I like to call it a new toy for an old game, because it's a new toy. It's an incredible technology that by focusing non-ionizing ultrasonic waves can heat or ablate tissue deep in the brain. This is very similar to what we used to do in the 80s and the 90s, which was called thalamotomies or pallidotomies, but it's definitely done in a much safer way, which is called non-surgical, although it's a non-surgical procedure performed by a surgeon, which is a little bit of an oxymoron, but there is no incision, there is no skull drilling, there is no brain penetration from a probe, there is no general anesthesia with outcomes that are comparable to those of the brain stimulation. So definitely something that can be, for in certain cases, absolutely an excellent solution. However, don't forget, it is a permanent lesion. Many people think, oh, this is not surgical, you're just kind of sending the ultrasound. No, we make it a small hole deep in the brain, very precisely. So it's an irreversible procedure. If it goes well, great. If it doesn't go well, we have a problem. There are a number of side effects that are not adjustable, like the brain stimulation. It can be done only unilaterally. There is no much knowledge about the long-term outcomes, because it started in the past few years, and definitely there is less expertise for the same reason. So I think UCLA has it, we also have it, so we believe in this procedure, but I find a little bit misleading that non-surgical sort of label, because it is a surgical procedure at the end of the day. Now, one question that is left unanswered 200 years after Dr. Parkinson first described Parkinson's disease is where it comes from. What is the cause? We don't know. That's the answer. We believe that there is a combination of environmental insults of different kind. Here you see the pesticides, but it's not just the pesticides, and genetic vulnerability. So basically, stress brought in by a number of factors in organism, in human beings that are somewhat vulnerable, will lead over time to Parkinson's disease. The environment seems to have a very strong role, and this is a map of the United States. The red is where Parkinson's disease is more frequent, is diagnosed more often, and it is in the industrial belt in the United States, in the Midwest, Northeast industrial belt. So there is an idea that probably something in the air around these factories or something that is associated to working in the industrial cities might be associated with Parkinson's disease. But there are other studies that show that if you are in an agricultural environment, you might have more predisposition to Parkinson's disease, probably again because of the pesticides. And there's some interesting theories that are these environmental triggers. So air pollution, pesticides, head trauma, very important, heavy metals, manganese especially, but also gastrointestinal infections, so colitis, virus that can change our microbiome, the world of bacteria in our intestines, I'll get back to that, can sort of start the process years and years before, apparently unrelated, but they put the ball in motion that then in predisposed individual may lead to Parkinson's disease. A lot of research still ongoing. But I want to bring your attention to the microbiome. What is the microbiome? It's the world of bacteria that live with us. And while you think that your body and your gut is yours, it's also home to trillions, which is thousands of millions of bacteria. So we live with over a kilo of bacteria in our body. And in fact, a friend and a scientist once made me laugh because they say, you know, if some alien, like in Interstellar, looks at us from above, we're really a big bag of bacteria walking around, which is an interesting concept. But these bacteria are not just sitting, and they're not those bad bacteria that give us diarrhea. They are actually good bacteria. They help us to do a lot of stuff, B12, vitamin K, but they are there and they take care of the food that we introduce into our body. We always think that we eat something and it goes straight into our blood, right? Through the intestine, it gets absorbed and then goes to the liver and to the blood. No, it gets eaten by the bacteria. We're feeding bacteria. And in fact, these bacteria do a lot of stuff that sometimes is not good. You might have had of the brain-gut axis. This is a big deal now in neurodegeneration in general and Parkinson's disease in particular. Why? Because people went to look at the world of bacteria in patients with Parkinson's disease. And guess what? Patients with Parkinson's disease have a different world of bacteria there. Is that important? Maybe. Because let's see, there are a lot of lactobacilli, Akkermansia, bifidobacterium is a tongue twister, but stick with me. And there are less than expected bacteria that are called Prevotella, Faecalibacterium, Lactospiraceae. Just stick with me. I don't know, these are, doctors like difficult words. They make us look important. The bottom line is that patients with Parkinson have a different world of bacteria there. Are we feeding the enemy there? Because these bacteria that seems to be particularly abundant, that's a theory of course, are probably doing something wrong. They may be actually the cause of the disease. Or if not the cause of the disease, the cause of the progression and the progressive worsening of the disease. And look at what feeds these bacteria. So the ones that are particularly abundant are fed by milk products and animal proteins, aka meat. And those who are poor in the guts of patients with Parkinson's disease are those fed by dietary fibers, fiber-rich fruits, grains, nuts, plant-rich diets. Did you have any doctor that told you to have more vegetable and fruits and fibers? Yes, probably all your doctors told you that. And these might be the reason. Not because they are better for you in general, but because they kill the bad bacteria and feed the good ones. And in fact, it's very interesting. This is by a work by Dr. Michele that encourage fresh fruit, vegetables, etc., because she found, interviewing hundreds and hundreds of patients with Parkinson's disease, that those who have fruit, vegetable, nuts and seeds, olive oil, etc., have a milder progression of the disease. Statistics, I mean, we don't know exactly what happens, but it's a matter of fact. And those who have more canned vegetables, fried foods, sodas, terrible, dairy, beef, pork, chicken, frozen vegetables have a faster progression of the disease. Statistics, a matter of fact. This is very important. And I want all of you, if there's one thing you want to bring home today, don't feed your enemy. Oh, and one more important part that I forgot. Do you know how long it takes to change the population of bacteria in your... Because I want to give you some motivation. Does anybody wants to guess? 30 days, 72 hours, 2 weeks, 1 week. 1 week. You change your diet for 1 week, and you change the composition of your biome. Amazing. It's amazing. And that's why a lot of people change their diet and say, oh my God, I feel so much better. And they say, yeah, right, it's placebo. No, it's not placebo. It's microbiome, most likely. Okay? This is a science that is evolving, but I find it extremely promising because there is nothing that we do more often than eating. Right? We're putting all those chemicals into our body every day, 3 times a day, at least. The only other things that we do as much is sleeping. And of course, that's just as important. Genes, about 15 to 20% of patients with Parkinson have a family history of the disease. Just by raise of hand, how many here have Parkinson's disease and a family member with Parkinson? Look at that. When I went to school, Adrienne is much younger than me, so probably genetics were already there. Parkinson's disease was not a genetic disease. Zero, nothing. Don't even think about it. It's not true. There are 20% of our patients that have a recognizable genetic variant. There are 23 genes, 99. It's evolving literally by the day. And the good news is that this is not a curiosity anymore. Now there are treatments that are being targeting these genetic variants, and I'll talk about that in a second. So, can we modify the progression of the disease? We already talked about the diet. What else? Exercise. You guys are good. So, there's been a lot of try. Trust me, there is no lack of try of trying to slow down the progression of the disease, but you can see from this cartoon, there are many, many, many failures. We got the wrong drug, the wrong trial designs. We're very good at finding excuses for failure. But the reality is, as we already seen, is that Parkinson is elusive. We don't even know if it's one disease. So it's objectively not easy. But we have a number of strategies. So first, lifestyle modification, exercise. Exercise, and again, I just come from a 10K. I try to lead by example, is very, very, very important. But it has to be exercise with a meaning. In other words, just walking around the block is not enough. We need to exercise at about 80 to 85, at least for aerobic exercise, % of our maximum heart rate. The way we know our maximum heart rate, we just subtract our age from 220. That's our maximum heart rate. Then you take away another 20%, and that's the heart rate frequency that we should exercise. Those of you that are able to exercise, with some intensity, should really get one of those Fitbit and check your heart rate, and make sure that you put down, if of course there is no heart condition and you want to speak with your doctor, and make sure that exercise is meaningful. Because look at this study, how the 80-85% maximum heart rate had a lesser progression of the disease than those who did not exercise. So eat well, sleep well, and exercise. I know, and I'm very flattered that many of you got my book, and I'll be very glad to sign it if you want. And there's a specific chapter on eat well, sleep well, and exercise. That in and on itself is gonna, as we already discussed with the diet, slow down the progression. Then we can try different medication. Rasagiline, many of you might have heard, it slows down the progression of the disease. That unfortunately is not true. There have been studies that followed this patient for many years, and as you can see, they all end up in the same place. But there are a few strategies that are worth at least mentioning. First is the genetic angle. So we already look at these slides, a lot of genes, but there are two in particular that are now the object of a lot of attention. One is called LRRK2, or leucine-rich repeat kinase 2, which is a large protein that is all over the body, and in fact is also associated with Crohn's disease, but it's very common in Ashkenazis and North African Arabs. But it's ubiquitous, but certain populations seems to have a higher percentage of this variance, G2019S, that predispose people to getting Parkinson's disease. The good news is that not everybody that has LRRK2 get Parkinson's disease, but up to 3 in 4 people. And when you get Parkinson's disease with LRRK2, it tends to be a little bit milder. Symptoms, milder progression, better response to levodopa. But it's still Parkinson's disease. I mean, it's not fake Parkinson. So we now are able, at experimental level, to try to treat LRRK2 because we know that LRRK2 is a protein that we usually think about genetic defect as something that doesn't produce enough or something. In LRRK2, we have too much of it. There is a excess of it, so we need to kind of slow it down. And so there are now a number of treatments that are under active clinical trial experimentation, trying to slow down this LRRK2 protein and therefore free up the brain cells from this potential cause of Parkinson's disease. So if you hear about LRRK2 clinical trial, pay attention to that. Are you guys doing it at UCLA, Adrienne? Luma and Lighthouse? Yeah, no? Well, then you all come to Cedars. It's okay. Yes. Another important gene is the GBA, or Glucocerebrosidase gene, which is also the cause of another disease. And in this case, which is more frequent than LRRK2, the type of Parkinson's disease is actually a little bit more severe. You see, however, that disease penetrance is incomplete. It's 8%. So if you have the GBA variant, you may never get Parkinson's disease. You need that environmental insult to help the genetic variant. In the case of the GBA, the enzymes, the glucocerebrosidase, which is an enzyme, is deficient. So in this case, we need to help the enzymes to do its work. There is a disease, as I said before, it's called Gaucher disease, but that requires extra abnormality. It's not what patients with Parkinson have. And there are a number of trials now testing possible remedies for GBA. You see them here, Ambroxol, Sanofi's, BL, and others. The bottom line is that the research is advancing and is now targeting these genetic variants. And if this work, would be the first targeted treatment for Parkinson's disease. If your Parkinson's disease comes from that genetic product and you can fix it, you may not cure it, but at least you can stabilize it. So the hopes are great. Of course, the research will need to give us the answers. In terms of trying to interfere with the progression of the disease, we all pay attention to the fact that Parkinson's disease is a synucleinopathy. Some of you may have heard this other tongue twister. Synucleinopathy means that there is a protein that's called alpha-synuclein that kind of gets clumped inside the cells of your brain and damages them, to make it very, very easy. And so scientists have been dissecting this alpha-synuclein to the minimal terms, trying to interfere with this inevitable progression of clumping and killing brain cells. And so you might be familiar with nilotinib, which was put a lot of, unfortunately, false hope in the population of patients with Parkinson a few years ago, claiming that participants were doing so much better. Unfortunately, it was a very small trial, only 12 people with no placebo. And so when they actually went to do a large trial, the efficacy sort of vanished, and nilotinib per se, not the idea necessarily, was swept aside. And this is, I'm going to take a little bit of an aside. Always be careful of press releases. Press releases are there to get your eyes, to get your clicks, and there's nothing specifically wrong with that, but sometimes they sort of augment and expand and exaggerate the importance of certain news. So take the press release, clip it, or screenshot it, and bring it to your doctor so that you can discuss with them whether this is something that is relevant, whether it's something that you should pay attention to or not. Because a lot of times we see cure of Parkinson found, and then when you read the fine print, a couple of mice have been treated, and now we hope to give it to patients, okay? How many times we have read that? So I love the press. There's nothing wrong. Nobody lies to you, but they exaggerate a little bit sometimes. This is another interesting trial that we're doing at Cedars and in many, many other sites around the world, which is antibodies against alpha-synuclein. Actually, the first attempt was did not work. Actually, 2 of them did not work. I'm not going to try to read these complicated names, but they found that in at least in this prasinezumab, which is the Padova study that is currently ongoing, on average, patients that were exposed to this antibody did better than those who were exposed to placebo. And so now we are trying to repeat it and to see whether this indeed will provide a long-term modification of the disease. It requires infusion. It's a little bit complicated, but it's definitely something that the world is looking at with a lot of curiosity. Neuroinflammation is a very, very hot research field in Parkinson's disease. This is something that we didn't think about it for many years, that the brain might be, that the Parkinson might come from a low-level inflammation in our brain. Even though there were a number of studies that by curiosity found that people that take a lot of ibuprofen in their life, for whatever reason, seems to have less chance to get Parkinson's disease, suggesting that if you get an anti-inflammatory, you get less Parkinson's disease. And so currently, there are a number of very interesting studies trying to block this brain inflammatory structure that are called the inflammasomes. And we don't need to go into too much detail, but these are quite advanced medications that try to slow down or to stop these inflammatory processes in the brain. Another interesting line of research is insulin resistance. Who has diabetes and Parkinson here, by raise of hands? A few. So we know that Parkinson and diabetes are close cousins and or close friends, but not your friends. Having diabetes increase the chance of having Parkinson's disease in life, and the common factor is insulin resistance. It's the difficulty of the body to respond to insulin that then brings to increased sugar in your blood, fatigue, and diabetes ultimately. And we found at Cedars-Sinai that over 60%, 2 in 3 of patients with Parkinson's disease without diabetes, without any diabetic problem, have insulin resistance. So they're pre-diabetic. And they have no idea about that because their sugar is normal. So we looked into that, and there are a number of associations between Parkinson and diabetes. the age, they're both diseases of aging, lack of exercise, predisposed both to diabetes and Parkinson, genetic predispositions, they have common predispositions, and obesity is a risk factor for both diabetes and Parkinson. So there have been a number of studies. This is an English study that was published a few years ago showing that exenatide, which is a drug for diabetes, is potentially effective for Parkinson's disease. And this is another study that we conducted at Cedars showing that liraglutide, which is a similar medication, also showed interesting improvements, not only in motor, but non-motor symptoms as well. So very promising. What about gene therapy? There are gene therapies available, but I think that this is still a highly experimental field. And so I'm not sure if it's something that I would recommend my patients to pursue. There is a lot of amazing research with optogenetics, chemogenetics, editing of the DNA with CRISPR techniques that maybe in the not so far future will allow us to surgically change, the abnormal snippets of our DNA. But as of today, April 1st, 2023, they're not ready for prime time, let's put it that way. And then there is no good what's new in Parkinson's disease lecture that cannot talk about stem cells. What about stem cells, doctor? Stem cells, there's a lot of research on stem cells. I show you before results of using stem cells as a diagnostic clue to study Parkinson, but obviously there are a lot of studies that use stem cells to try to treat Parkinson. It's very difficult as of today to distinguish academic clinical trial transplantation trials that are serious trials, so to speak, with less serious trial. My rule of thumb is that any trial that will ask you to pay $50,000 to participate is not a serious trial. It is a trial that preys on desperation, lack of, which obviously doctors are responsible for, but please don't break your bank to do a stem cell trial that asks you $50,000 to $70,000 just to participate. It's not serious. A clinical trial should never ask you to pay. Clinical trials should be funded by a scientific agency, the NIH, the Michael J. Fox Foundation, whatever. The $140,000 that I raised for running the marathon, but not based on your savings. Okay, that's my opinion, and I'd be more than glad to discuss that. So, but beware of the stem cells panacea. So, Parkinson's disease, fastest growing among neurological diseases, fast growing knowledge, changing our approach to the disease, a lot of knowledge gaps. We don't know the cause, the mechanisms, when really the disease starts. So, as I said before, the more we know, the more we know we don't know, which is good, trust me, it's good. Maybe one disease, maybe many diseases. This is a major questions that we are actively scratching our head on. It may start several years before the onset of the tremor or the rigidity, and this is a window of opportunity for early diagnosis and hopefully modifying the course of the disease. There are a number of advanced treatment strategies for those who obviously already have the disease, and we cannot stop it from happening. Infusion therapies, deep brain stimulation, focused ultrasound, gene therapy, and possibly cell-based therapy. And last but not least, we need to move on from the exclusive focus on dopamine, dopamine, dopamine. I know it sounds like Trump with Russia, 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 but we have to stop with dopamine, 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 and understand that the disease has a much larger impact on our body, and we need a multidisciplinary approach. We need several doctors with several competencies and expertise to truly take care of you. Thank you for your attention.